Bonjour tout le monde. Hello, everyone. Welcome to today's online event featuring an excellent speaker who will discuss advocacy for the health human resource crisis in Canada, a discussion on internationally trained physicians. Before we begin our webinar today, we would like to acknowledge that N4 and CMA are located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples, and their valuable past and present contributions to this land. As well, with September 30th being National Day for Truth and Reconciliation, we acknowledge on this day the children who never returned home and survivors of residential schools, as well as their families and communities. Public commemoration of the tragic and painful history, along with understanding and recognizing the ongoing impacts of the residential schools, is a vital component of the reconciliation process. On September 30th, it is encouraged for all to wear orange to honor those thousands of survivors of residential schools and those who tragically did not come home. With that said, thank you for coming today. My name is Andrew Tomeyer. I'm the education coordinator with N4. I use the pronouns he, him. I'll be hosting and moderating today's presentation. My co-host is Colleen Drake, who will be monitoring the Q&A box today. I'm now pleased to introduce you to today's presenter, Owen Adams. Owen, I'm going to ask that you turn on your video as I introduce you. Owen is Senior Advisor to the CEO at the Canadian Medical Association, based in Ottawa. Since joining the CMA in 1990, he has contributed to the association's research and policy development in areas such as physician human resources, health system financing, and health reform. Prior to joining the CMA, he spent 12 years in the Health Division of Statistics Canada. He holds a BA and MA in sociology from Western University and a PhD in population health from the University of Ottawa. Thank you for coming today, Owen. A few housekeeping pieces. Today's session is being recorded and will be uploaded to our N4 platform. We will share this with you as soon as it becomes available. Should there be any technical issues during this webinar, we will inform you with details for an alternate makeup session. And before we begin today's event, I would like to take a moment to introduce you to our platform features to help enhance your participation experience. Throughout today's session, we invite you to write your questions in the Q&A window. We know that sometimes many of you might have the same question or be interested in a particular response. So we do have the option to upvote questions for us to prioritize which questions we are to ask Owen. Our speaker today as well has no conflicts of interest to declare. So with that said, let's jump into today's presentation, for which I will pass the virtual podium over to Owen.
Great. Thank you very much, Andrew, and for the invitation to speak today, and thank you for the acknowledgement, the land acknowledgement that you made. Thank you. I'd first congratulate the National Newcomer Navigation Network on the excellent work that you're doing. As you know, the federal government has ambitious immigration targets over the next few years, from 432,000 this year to 451,000 in 2024. And I would expect that many of them will be trained and experienced healthcare workers, anxious to put their training and skills to work in Canada. So I think you've got your work cut out for you. Next, please, Andrew. Okay, so I was asked to speak about the current physician supply and also to focus on international medical graduates. And I'll be using the acronym IMGs fairly typically. That's very commonly used. And for definitional purposes, an IMG is generally considered to be someone who received their medical degree from someplace other than Canada's 17 medical schools. And I hope that I won't overburden you with numbers and statistics, although I come by it honestly through my prior years at Statistics Canada. And I've listed several URLs at the end that would provide good sources of information. And I think that the deck will be made available to you. Can I get the next, please, Andrew? So I just want to start off with a few indicators of Canada, just to show how we've changed over the last 20 years in physician supply. So these are data from the Canadian Institute for Health Information. And as you can see, the ratios of family physicians and other specialists per 100 population have both actually exceeded growth over the 2001 to 2020 period by more than 25%. So family docs, this is an example, going from 95 per 100,000 to 123. So some other key facts. So the proportion of female physicians has increased from 30 to 40%. and the proportion at age 65 and over has increased from 9 to 15%, although the actual average age only increased by 1 year to 49. I guess notably for today's presentation, you can see that the proportion of IMGs has increased from 23% to 26%. And I think that one factor for this could be increased capacity for into IMGs and postgraduate training, but the databases don't really capture the location of post-MD training, so I can't really tell that. But just generally, Canada has always relied on international graduates, and the figure of 1 in 4 practicing physicians has been steady for some time. Next, please, Andrew. Great. So how did we get here? So in the early 1990s, there was a 10% enrollment cut in 1993, and we started to see a physician shortage by 1995. So what that slide shows is two projections. The first was what we observed at the end of about 1999, and the second projection is based on the results of a projection model that we developed right around that time. And as soon as we issued the first projection that showed supply going down to about 1.4 physicians per thousand by 2021, that's when enrollment started increasing. So the blue line at the top, if you draw a vertical line from 2016 down to the green line, the difference is 10,000 doctors. So those increases in medical enrollment, they made quite a difference. Can I get the next, please, Andrew? So this is sort of roughly where we are today in comparative perspective. So for some time, we rank near the bottom of the rankings for physician supply, according to the OECD, 29 out of 38, and as of 2019. And so we have increased our enrollment over the time. You can see, we're now up to 7.6 medical graduates per 100,000, but that's still more than 40% below the OECD average of 13.2. So, we haven't really improved our situation in relative terms over that period of time, simply because everybody's expanded enrollment. We've seen recent announcements in Canada. Ontario is announcing medical enrollment going up by 160, and a new medical school at Brampton. And there's other provinces are thinking about this as well. But this is roughly where we lack. But I guess what I would say about this slide too is that compared to some of the other G7 countries, we're not that, we don't look so bad. For example, the US has 2.6 physicians per thousand. That's just a little bit less than we have. So, we're not that out of line with some of the leading countries. So, it just begs you the question as to sometimes why we figure that we've got this, what are the factors contributing to our shortage situation here? Could I get the next, please, Andrew? So, while the overall projections indicate that we're going to have an increasing physician supply, it seems to us there's a mismatch between what the education system is producing and what's being demanded. Every year since 2013, we've been doing a compilation of advertised jobs in all the government websites across the country, and we compare that to the previous year's postgraduate training output. So what this table shows you, as of December 2021, there were 2,400 advertised jobs for family doctors across Canada, and yet the post-MD system only graduated just under 1,500 in 2021. And of that 1,500, about 300 were subspecialized in things like emergency medicine. So, that's a gap of 952. It's pretty significant, and it's gone up. It was only about less than 600 the year before. And on the other hand, if you look at surgical specialties, you've got there were fewer practice opportunities than there were postgraduate exits. And just to give you one example, in orthopedic surgery, there were 7 advertised jobs versus 84 graduates in 2021. So that's certainly a piece of the issue that we have here. Can I go to the next, please? So, you can't simply look at head counts. I think you actually have to look at sort of activity levels. And this is a slide from reported a while ago based on administrative data. And this is looking at family doctors in Ontario from 1997 to 2017. And what you see there, the actual number of, visits in a year has declined. The number of days that are being billed for has declined. The number of patients seen has declined to some degree too. and as well as the number of, sort of like visits per patient day. So, and then there's a variety of factors for that. I mean, doctors do other things besides direct patient care. And it's also, I think, been made the case when I showed this to a group of doctors that patients are probably more complex than they were 20 years ago. I mean, the leading edge of the baby boom hit 75 in 2021. I think we're going to feel that over the next few years. Can I get the next, please? Thank you. Just a couple of indicators in terms of, our current situation. So this is a recently published poll by the Angus Reid Institute. And so that they're basically saying that 1 in 5 Canadians does not have a family doctor. And of those that do, 1 in 3 experience difficulty in access. And that, in comparative perspective, StatsCan just released their 2021 figures, and they show that for the population 12 plus, that 15% did not have a regular health provider, and that's basically 4.7 million Canadians. That's up a little bit over 2020, which was 4.6. So, and it's not just a primary care issue. People experience long waiting times to see specialists for diagnostic and surgical procedures as well. And I haven't really delved into any of those data. Next slide, please, Andrew. Just a couple of other indicators of this. So this is from the Commonwealth study of 11 different countries. And so this is from 2017. And this is of Canadians 65 and over. And Canadians were significantly, by far, the most likely to have waited 6 or more days to get an appointment. And next slide, please. And similarly, we're among the top at 34%, basically the third highest in terms of the percentage of older adults to seek care in an emergency room in the past 2 years. So we do have a significant, there's a workforce crisis right now. And I'm only speaking about doctors here. We know that this is also a major issue for the nursing profession, groups like personal support workers as well. But, I basically only have data on physicians. Can I get the next, please, Andrew? So this gives you an indicator. In the summer of 2020, we commissioned Deloitte to try and estimate what was the backlog of diagnostic and surgical procedures. They were focusing on 5 areas of the Wait Times Reduction Fund, things like knee replacements, heart surgery, cataract surgery, etc. And they estimated the cost of that backlog would be $1.3 billion as of the fall of, in 2020. They did another study for us in 2021, and this is some of the findings are featured here. You can see quite significant care gaps, and most significantly, they were claiming 4,000 excess deaths not related to COVID-19 due to delayed care. And the backlog remains high. This is from 2021. So earlier this year, the Ontario Medical Association estimated that 21 million procedures are backlogged, including more than 1 million surgeries. Other provinces have reported similar figures. Can I get the next, please, Andrew? So, in terms of, the pandemic has taken its toll on health workers. And this slide is taken from the results of the 2021 CMA National Physician Health Survey. And what you can see is that more than 1 in 2 physicians and postgraduate resident trainees was considered to be highly burned out, compared with just under 1 in 3 in 2017. That's quite a remarkable increase. You can see on the right-hand side, they report higher rates of burnout among groups, and you can see greater impact on resident trainees, female physicians, younger and early career physicians, and those in rural and smaller communities. And as I said, this burnout, this affects all frontline health workers, but again, we only have data for physicians. So I just like to turn now to what we think could be done about this growing crisis. So could I get the next, please, Andrew? So in the 2019 federal election campaign, we joined with the Canadian Nurses Association and the College of Family Physicians of Canada to put forward a recommendation calling for a primary care transition fund to enable the scaling up of team-based primary care. Well, only 3 provinces had managed to do this over the past 20 years, I guess. And so this made it into the campaign, into a couple of throne speeches, but we haven't seen much concerted action. Most recently, in the 2021 campaign, the government in their campaign pledged $3.2 billion to hire 7,500 family doctors, nurses, and nurse practitioners. So we got going right after the morning after the election to try and come up with some recommendations that they could act on. And it took us a while to get it together, but we got it done earlier this year. And And we've been advocating it in places such as the House of Commons Standing Committee of Health, and I'll just highlight them briefly. And so, can I get the next, please, Andrew? Great. So these are the first two, and I'm not going to go over these in detail. I will provide. I think I've got the URL somewhere. Maybe it was on the previous slide. Sorry. But anyway, so, we put retention first. They tell you in marketing class that it's easier to hang on to an existing customer than to recruit a new one. And it's certainly similar for healthcare workers. It takes at least 5 years to train a family physician. And but basically, so far, the only measure we've seen in the 2022 budget was Canada's student loan forgiveness for doctors and nurses locating in rural and remote areas. Recommendation 2 was to address the administrative burden on health workers. This could include measures like increasing administrative clerical staff and cleaning staff in nursing settings to allow more time in direct patient care. And we're starting to explore the elements of administrative burden for physicians. Doctors have long complained to us about third-party forms. We're hearing something about electronic medical records as well. We're looking more into that. Can I get the next, please? The third recommendation, which I mentioned already, it called for a federal fund that would support provinces and territories in scaling up team-based models of primary care. Provinces such as Alberta, Ontario, and Quebec have done this at scale already, but they haven't finished the job, and other provinces are interested. The fourth recommendation calls up for scaling up virtual care to support team-based approaches to virtual care, and really to solidify virtual care as part of the publicly funded delivery system. There are a lot of private actors in this space, and we think this really does need to be part of the future of Medicare. Can I get the next, please, Andrew? Thank you. So fifth, if we're going to ramp up the training of healthcare workers, we're going to need new infrastructure for teaching and research. The only previous federal investment in this was in the 1960s, and that built a number of new medical and nursing schools. And then the sixth recommendation, and that we need to expedite the licensing of internationally trained physicians and nurses. And for physicians, one thing in specific, we're recommending expanding practice-ready assessment programs, and I'll come back to that. And you're starting to see provinces getting interested in this as well. The next, please, Andrew. Thank you. So seventh, we think that given the evidence that we have on the rise of burnout during the pandemic, there's a need for a mental health strategy for healthcare workers. And one aspect of this would be at least to improve data on the wellness of a variety of healthcare workers, because at the present, we only have data collection on physicians, to my knowledge. Eighth, we echo the call that many have made for improved data on the healthcare workforce. At the present time, we only have detailed information on physicians and nurses, and much of what we have for physicians is based on administrative billing data. I think there's also a need for better coordination across jurisdictions. For example, not all provinces and territories can support training programs for some of their health workers. They need to rely on other provinces, and I don't really think they plan that well, with the perhaps exception of Nova Scotia, I think. Next, please, Andrew. So we tried to lay them all out in an 18-month roadmap. And as I noted, though, the only HHR measure announced so far was an increase in Canada's student loan forgiveness for doctors and nurses practicing in rural areas, and a commitment to expanding the list of eligible professionals, which we heartily support. The House of Commons Health Committee is expected to report on its Health Human Resource Study in the fall, and this will give us, opportunity to reinvigorate our advocacy for the 2023 budget. We certainly think the federal government has a role to play. And also, as I mentioned, I think there are signs that the provincial and territorial governments are getting the message that we have a health workforce crisis. Next, please, Andrew. Something else that we've done, jointly with the Canadian Nurses Association, we convened 2 health worker crisis summit meetings, to which we had a variety of health disciplines there, and we've had 2 of these, and again, this is all supporting advocacy, and as a recent example, the Ontario government has written recently to both the nursing and medical regulators asking for a plan in 2 weeks on how they propose to fast-track internationally educated nurses and doctors. And some of the Atlantic provinces are offering significant funds to attract physicians to rural communities. And Again, I can't speak for other disciplines. So now I'd like to turn my attention to international medical graduates. So can I get the next, please, Andrew? As I said earlier, nationally, 1 in 4 practicing physicians receive their MD degree from a medical school other than R17. And you can see a lot of variability across the country. The highest percentages are observed in Saskatchewan at 49% and Newfoundland and Labrador at 33%, and the lowest in Quebec at 9%. Newfoundland and Labrador has actually managed to improve their self-sufficiency over the last decade or so, and I think it's probably due to greater retention of their graduates from Memorial University, but I'd have to check further on that. Quebec has been historically low. Language probably has something to do with that. And I think so the process basically in these two provinces that are really high, I think, the approach would be that physicians would generally come and manage to get a provisional license with the expectation that they will meet qualifications for full licensure in 3 years. I mean, you'd really have to look at the individual college requirements for that. And next slide, please, Andrew. And this gives you, I showed this sort of interest. It shows you where our international graduates have come from. So this is taken from the CMA data, and I compare two cohorts. There are those that graduated before 2000, and that's basically about 30% of the total of practicing, and those that have graduated since 2000, and that's about 69%, as you see at the bottom. And you can see a shift in the patterns of origin of where these people have graduated from. Again, this is not where they were born. This is where they got their MD degree. So you've seen increases in Ireland, Australia, and schools in the Caribbean, and you've seen a diminished share of graduates from the biggest countries of South Africa, India, and the UK. And so, interesting these increases from Ireland, Australia, and the Caribbean schools, because we do not have data on the origin of these physicians, but I suspect that some of them are Canadian-born persons who studied offshore. Canadian education is highly competitive. You've got roughly 5 applicants for every first-year position. And the only report I've seen was done in 2010, and it estimated then that there were about 3,500 Canadian medical-born students studying offshore. Anyways, like I said, we don't know the country of origin, but this is what I would suspect anyway. There's been an increase from the US, and I think that's more complicated to understand, because while in the 1990s we lost thousands of doctors to the US, since that time, more have come back each year than have left. And, I don't really know what the factors of that are. Next, please, Andrew. So I wanted to talk about then standards for medical licensure in Canada. So licensure of regulated health professions is up to the provinces and territories, as is set out in the Constitution. However, the Medical Council of Canada was established in 1912 to promote common national standards for the profession. And here are the core elements that have emerged over time. A recognized medical degree from something recognized by the World Directory of Medical Schools. There are currently more than 2,900 listed in that directory. The Licentiate of the Medical Council of Canada, that's based on the completion of an exam. I'll say a little bit more about that. Completion of postgraduate training. In Canada, that would be either family medicine or one of the specialties of the Royal College or the Collège de Médecins du Québec. And then certification as well, sort of recognizing completion of postgraduate training. Where you will see differences across the colleges is how medical graduates from other than 17 medical schools are treated. And this is it's an international phenomenon, certainly with countries like Australia and the UK that are also heavily reliant on international medical graduates. Next, please, Andrew. There's been a lot of, I would note that there has been certainly changes over the last 20 years. So in the early 2000s, there were a lot of concerns about the access of IMGs to postgrad training in Canada. Health Canada convened a task force that brought together regulators, provincial governments, associations for IMGs, and other bodies. And this report was reported in 2004. And almost immediately, Health Canada made a modest investment in sort of education related to IMGs. One of the outcomes was the creation of something called a National Assessment Collaboration, which is an observed standardized clinical examination that IMGs were required to take in order to apply for postgraduate training in Canada. And what you've also seen that since that time are increases in the number of postgraduate training programs dedicated for IMGs. This report is no longer on the website, but there's really a lot of good discussion on the issues, and I could certainly just email it to anybody who's interested. Next, please, Andrew. These are just a few key terms from the Medical Council of Canada. So this related to the MCC.CA Part 1. It's a one-day computer-based test that assesses the critical medical knowledge and clinical decision-making of a candidate expected of a medical student who's completed their medical degree in Canada. So this would typically be taken also by a Canadian, one of our Canadian students, like in about their last year, I guess, of their undergraduate program. And this would be required in order to get that licentiate. So international graduates challenge this exam as well. Second, the National Assessment Collaboration. That's a one-day exam that's assesses readiness to enter Canadian residency program. It's a national standardized exam that brings the knowledge, skills, and attitudes essential for entrance into postgraduate training in Canada. And the intent of this really was to try and standardize sort of admission across Canada. And lastly, the Practice Ready Assessment Program. These are programs that are offered in 7 provinces as a route to licensure for international physicians who have completed residency and practice independently abroad. These programs offer clinical field assessment over a period of 12 weeks, followed by a return of service. And this is something that like 7 provinces have it. I think Ontario does not, but in their reply to the government, the College of Physicians and Surgeons recommended such a program in Canada. That this was recommended a couple of weeks ago. So that's something I certainly think you could expand capacity in that regard. So the next slide, please, Andrew. So the route for international graduates that basically do not have postgraduate training is to go through the Canadian Resident Matching Service match. And so these are the results from the 2022 match. So medical students apply in the last year of their program, ranking in which they rank disciplines and programs. Academic programs rank students on the basis of interviews, and a computer algorithm matches them up. So there are 2 iterations to this match. The first is restricted to graduates of essentially North American accredited medical schools, except for the provinces of Saskatchewan and Quebec. They do not restrict. So you can see in the first round this year, there were 331 designated positions for IMGs, and there were 1,138 participating. There were 3,075 positions offered for Canadian medical graduates in the first round, and 2,900 were participating. So ultimately, between the first and second round of the match, there were 439 IMGs matched and 2,844 Canadian medical graduates. This is one of the problems of our system. It's very tight. There's very little flexibility. And so you can actually see that while there were many unmatched international graduates, there were 109 Canadian medical graduates unmatched after the second iteration this year. And there's basically no room in the system for re-entry training right now. There used to be, but not now. The next, please, Andrew. So, and then this just shows you, this is from the most recent annual postgraduate trainee census. And this is the top 10 countries of MD degree for Canadian citizen permanent resident trainees in Canada in 2021. You can see Ireland top of the list at 497. Again, I suspect that some of these will be Canadian-born students who have studied in Ireland, the UK, and Iran. You can just see, and Grenada again in the Caribbean is at 65. So again, I specify that I have to emphasize we don't know the country of origin. It's just I guess anecdotally sort of the kind of things that we suspect, I guess. Anyway, could I go to the next, please, Andrew? So just a few concluding observations here. So the World Health Organization is projecting a shortage of 15 million health workers in 2030. There's going to be global competition ahead, and we need to keep that in mind. If we, both from inflow and outflow of graduates. Secondly, Canada and other countries will continue to rely on internationally educated physicians and other health workers but we need to be conscious of ethically recruiting people. You know, you don't want to recruit from countries that do not have great work, you know, large workforces and can ill afford to lose people. I remember one night invited to dinner at the South African High Commission about 20 years ago. You know, it was a source of many Canadian doctors, and I just got blasted really for recruitment. Third, there's a need, I think, for longer range integrated health workforce planning that takes into consideration the whole range of health disciplines and settings, you know, from community to institution, and regional and national coordination of education and training. I mean, there's something, you know, like I said, the mix that we're graduating out of the post-MD system is not lined up to what the advertised need is, based on that slide I showed earlier. And then lastly, you know, in 2009, the Senate of Canada estimated that social determinants of health, you know, things like education, income, housing, accounted for 50% of population health status, and healthcare at 25% at best, and I've seen much lower estimates. And I was struck, there was a paper in 2010 by a fellow by the name of Johannes Mackenbach that estimated in 2004 that social inequalities accounted for 1/5 of healthcare spending in the European Union. And that's a big number. And we've not really engaged on that in Canada. And I think we really need to, or we're going to continue to experience a shortage of not just human, but other health resources. I mean, we need to do some more upstream thinking about what causes, about the determinants of ill health, because, I said at 25% at best, healthcare alone is not going to solve it all. Can I go to the next, please? Okay, so these are just some of the URLs for some of the information sources I've mentioned. There's a wealth, like, for example, the Federation of Medical Regulatory Authorities. They have links to the provincial territorial regulators, at least on their website, and so you can easily look through what the different provinces and territories require. Canadian Institute for Health Information has lots of data on the physician workforce. And then lastly, there was a very comprehensive report published by the OECD in 2019. I haven't read the whole thing, but there's a good chapter on the Canadian situation. And I forget which chapter it is. I had a look at it. It was done by some folks at McMaster. So go to the next, please. Thanks. And so that basically concludes my presentation. And I'd be happy to take any questions. And my email was on the very front slide. If there's anything follow-up after, I'll be happy to try and answer it. So happy to take questions. If I don't know the answer, I will tell you that, and I will try and find it for you. So thank you very much.
Thank you, Owen. That was a great presentation. Very knowledgeable on the data side and very good understanding of what's going on with IMGs, where they're coming from, and the like. So thank you for that. And so with regards to this, we have quite a few questions that have come in. So with regards to the data that you presented in the first part of the first half or so of the presentation, does that include Quebec in terms of some of the statistics that you provided?
Well, the national statistics would include Quebec, absolutely.
Okay. Well, thank you for that. So with regards to CMA and its role, what is the role of CMA in encouraging faculties to produce graduates more and create more family physicians?
Oh, okay. We haven't. Okay, basically, our role is one of advocacy. We have, advocated. I think we played a key role in the decision to increase enrollment post 1999. It was our projection model that I showed you the results of. So it's one of advocacy. No, we don't. Education is. We consider that is primarily the purview of the 17 medical schools represented by the Association of Faculties of Medicine of Canada, and the certifying colleges. So that's the Royal College of Physicians and Surgeons. I think they've got about 69 specialties and other areas. The College of Family Physicians of Canada and the College de Médecins du Québec. They license physicians in Quebec and they certify. So altogether, between those colleges, there's about 106 specialties and subspecialties that they recognize. So we have not heretofore specifically made representation on which specialties ought to be trained more of. We've been generally advocating for the overall increase in enrollment, and maybe we should, but we haven't heretofore.
Thank you. Thank you. And in a similar question in terms of how IMGs who have completed their exams, applied for residency, but weren't accepted, is there a plan to increase the number of these residencies or be able to fill spots that may come open for potential IMGs?
Yeah, I don't know. I see. We've generally advocated for we've advocated generally for increased flexibility in the post MD system, and we've always advocated that there needs to be capacity in that system for IMGs. It's and I don't know. I think with as I said, there has been a significant increase in designated positions over the last 2 decades, and we'll see now. I think governments. I think you're going to see governments thinking with the colleges, how can they do even more sort of fast tracking, not necessarily through the post MD system. It's long with a statistic that we do not have is how many IMGs come fairly directly to practice versus come through the post MD system. And I think it's widely believed that more come through fairly direct to practice than through the post MD system, but we don't have the numbers on that, unfortunately.
Right, right. Of course, of course. And thank you for that. One of the other questions that I actually came to mind when I was when you were presenting was with regards to those policy recommendations. What do you feel would be the easiest to implement across the country, and what would you feel would be the most difficult to put in place?
Well, I mean, probably the short things looking at retention are probably that's the smartest thing to do. I think to hang on to your existing workforce. I think those other things, some of the the retention stuff. I think some of the things could be done with tax policy, for example, like student loan deferral. That is done through federally, but I think you could probably do things through the tax system that would do that. And I think in terms of a primary care fund. I mean, there was a previous example of that was rolled out in 2000. Over the next few years, you have to think about capacity. I mean, I guess the training capacity is generally sort of fixed at a moment in time. So I don't think, you'd probably have to take an assessment of that to see realistically how much untapped capacity do you have. We don't know that. We've certainly recommended that ought to be done. Really looking forward to the health committee report. It should hopefully come out in October or something to see what they've got, because they heard from a lot of people and a lot of different disciplines as well. I mean, that's the key thing. This is a lot bigger issue than doctors and nurses. We need to hear from, we need the voices of other health professions need to be in this mix as well.
Right, of course, of course. And to add to that, with one of the questions from the audience was in regards to the retention policy piece. Family physicians are so important, yet seen as a lesser specialty in Canada. How can we change this perception and support their retention within the field?
Yeah, no, great question. And the College of Family Physicians is working very, very hard on that. They've had a recent mammoth report or major report come out on looking at the future of the training of the discipline. And so, they've really been working hard really to, and it's just to, hopefully keep at it. I think it's come a long way. I mean, I think the college CFPC was established about 1954, and so they've been working hard, but really redoubling their efforts over the last few years.
Thank you, thank you. One of the other questions we had was with regards to IMGs who become out of practice due to the wait period for residency. Are there plans to offer trainee clerkship programs to overcome the out of practice barrier? They state IMGs have to go back to their countries of origin to practice again if they can, and then have to come back to Canada. Is there any sort of plans to help mitigate that potential cost of travel for them, so that they have to go back and whatnot?
I need to get back to you on that one. Sorry. I think I've seen something recent on that, but I need to check into that one.
Oh, yeah, of course. That's all right. That's all right. Thank you. For IMG statuses, does that, in the data that you presented, does it include immigrant IMGs or both immigrant IMGs and Canadians that studied abroad?
Yeah, sorry, I tried to make that point several times. Our definition is somebody who graduated from someplace other than our 17 medical schools. So yes, it would include both. Yeah, and unfortunately, we do not have data to differentiate.
Thank you. Thank you. Does CMA track statistics for IMGs compared to non-IMGs on burnout or retention?
I think the short answer is no, sorry. And I don't know if our national, I'll have to check or to see if our national physician health study did have that question on there. And that, because if that doesn't, then I'd say we don't have it.
Okay, thank you. One question, a quick one was, so we will asked with regards to that licensure of international med graduates from 2004. We will provide that within our resource toolkit and with after the presentation has concluded.
Okay.
So thank you
I
for
sent
that.
that to you already, I think. Yeah.
Yes, yes,
Yeah,
we will
okay.
provide that. That was just one of the questions. One of
Okay.
the other questions is IMGs from so many countries do not have the 2 years of family medicine training residency. What are their options at this point? Are they only eligible for CARMS residency, or is there other potential routes to professional practice?
That is, yeah, I think, yeah, I don't know. You'd have to check out what the eligibility, you'd have to look into the eligibility for what the practice ready assessment programs are. Otherwise, I think it would be through the second iteration of CARMS.
Okay, thank you. Thank you. We have a question from Joan Atlin. While CMA does not play a role directly in the licensure process, what role do you think the CMA could play in helping bring together the range of stakeholders, government, regulators, medical faculties, together to address how to move forward CMA, CNA, CFPC recommendations on licensure for internationally trained doctors, especially those who are licensed to practice in other jurisdictions?
That's a great question. Thank you, Joan. And Joan was on that task force in 2004, by the way. Yeah, I don't know. I mean, we haven't. Yeah, it's a good question. We haven't really. We're starting to notice the recent attention on this, and I don't know. I guess it's something to take back, Joan. I guess.
Thank you. With regards to some of the data, one of the questions that that came to my mind was when you presented that access graph and it showed 3% doesn't want or doesn't need one. Did it go into details into what the reasons were with regards to not wanting or not needing one? Was it are they content with, say, going to walk-in clinics? Are they physicians themselves and just self-diagnose once in a while, or have they just sort of given up trying to find a family physician?
No, no, I don't think those data do, but the stats can data do. So the 2021, I can follow up with that because they just came out and they ask reasons like didn't need one, couldn't find one, and that. So I'll do a tabulation of that and send it to you after, and you can distribute that.
Thank you. Thank you.
Unfortunately, people can pick more than one reason. So see, it doesn't give you the top reason, but it gives you the distribution of the different reasons. So I can give you that for 2021. I've got it.
Yeah, that was one that popped in my head when you were presenting, which was really interesting to think about. One of our questions is, what training can we provide to IMGs to get them to the Canadian standards, and how would that increase the chances of recruiting IMGs?
Well, again, it's a question that comes down to, obviously, the gold standard, I guess, and that's my term, would be through the Canadian post-MD system, and that. But then, short of that, then we have the practice ready assessment, and then I don't know. I think, possibly now there will be some look at, are there other kinds of training options? There's not, certainly not that much flexibility right now, but maybe with all this attention, maybe some, maybe some options will be forthcoming.
Thank you. Thank you. A quick question was, you had mentioned a report from McMaster. What do you have on hand the title, or will you be able to provide that?
I put the URL. It was my last slide.
Okay.
And it's not a freebie. You have to buy it, but you can read it for free online. Okay. And I think it's chapter 7 is on Canada. Arthur Sweetman was one of the authors of it. So I put the URL there.
Thank you. Thank you. The unmatched residency spots per year is very high, especially during the pandemic. Is there work being done to look into the reasons for that? Any mitigation strategies, any mitigation solutions to ensure these positions get filled?
Well, I think you'd have to look at it, but I think if memory serves me, and I've heard this, and I would need to check, but a lot of the I think a significant number of the unfilled positions this year, and I think for a few years have been in Quebec in family medicine, and that so then but I'm not aware of any systematic inquiry into why people have various speculations that I won't delve into, but it hasn't something that I guess you could look into it, yeah. And it's it's good to look at the pattern, I guess, and certainly the CARMS data. They tell you where the positions were unfilled and what discipline they are. So you'd have to basically have a look at that.
Okay, thank you, thank you. One of the questions relates to return for service agreements, and in terms of the divide between IMGs and Canadian graduates, is there a reason as to why Canadian graduates don't need a return for service requirement compared to IMGs?
Well, I think the return of services. I think that is attached to. I believe that would be attached to the practice ready assessment programs. That would not be. That would not be. I'm quite sure that is not a condition of those who come through the post MD system, the regular post MD system.
Okay. All right. Thank you. As well, is there a central database where IMGs can connect with physicians in their geographic location and possibly open to hiring an IMG clinical assistant or take on IMGs for observerships?
Yeah, unfortunately, not to my knowledge. Not to my knowledge.
Okay. You mentioned that there used to be more room for reentry for training. The question is essentially, what was that room for reentry, and why was there room for reentry?
Well, I think basically it became a problem. I think in 1992, they adopted sort of essentially 2-year pre-licensure training. Before, up to 1992, you could go into essentially get your MD degree and do a rotating internship for 1 year, and then go on. But then I think when the requirement for 2-year pre-licensure training became required, that took up a lot of positions, and I think that it was at that point, I think that squeezed a lot of the excess capacity out, and so that was probably around the time I think that reentry training got very difficult.
Thank you. Thank you. Thank you so much for all these questions, by the way, attendees in the audience. These are very informative, very good. Many IMGs end up in rural communities, but the statistics show higher burnout, as well as retention being an issue. What are key barriers to physician practice in rural communities? Does CMA have any supports for rural physicians?
We don't offer any direct support, no. But so in terms of what are the barriers? I mean, it's a lot of it is the sort of the burden. If there's not that many physicians in the community, you've got the burden of being on call more than you would want to be. Like maybe 1 and 2 call or something, and there's also there's family considerations as well. I mean, there's a lot of dual physician couples, right? And so one spouse might be a family doc, the other might be some sort of a specialist that needs to work in an academic center, and that can be a challenge as well. It could be other family issues as well, but I think you're starting to see, for example, like in BC, they have introduced a program that sort of through virtual care, that basically in consultation, that a doctor out in an area knows that they can connect virtually and get support from a physician colleague from somewhere. I think they've had some success with that. So I guess if more can be done, to provide sort of professional support for people in these areas, but basically, the chance to get out and take a break, take a holiday, and I'm not really aware. I think there might have been 1 or 2 provinces in the past that had something like a locum pool, and I don't know if I honestly don't know the current status of those. But I mean, I think those are some of the factors.
Thank you. Yeah, those was very, very good. Very good. Thank you for that. With constant changes in terms of governments, in terms of government priorities, and priorities seen by the public. How do we maintain the discussion and the need to continue those long-term strategies and continue sustainable change?
That's a great question, because all too often, because I can tell you, so that in the early 1990s, the governments were seized. I mean, it was health ministers that collectively decided to reduce enrollment by 10% in 1993. So it was like doctors not welcome was the sign out there. But then, and so everybody was wanting to introduce like physician plans. Like Ontario introduced, I think in 1993, they introduced a 2-year moratorium on medical licenses, or maybe it was billing numbers, sort of, to physicians who had not completed their MD degree or the postgraduate training in Ontario. But then in 1995, lo and behold, a physician shortage emerged. It started in small, like small cities, maybe the size of maybe Moncton, New Brunswick or something, and then it quickly spread. And then so as soon as that happened, everybody forgot about the whole physician planning thing, and the government essentially become then seized with, what can we do with models of primary care? So it's like sort of it tends to go in fits and starts, and I hope now, I mean, it's taken a while. It's only recently, I think, that you've seen governments start to recognize that there is an HHR crisis out there right now, and hopefully that that they won't mitigate the situation enough that they'll forget about it. Because, we really think that there needs to be a long-term plan. I mean, the term boom and bust has been often used to describe our workforce. It tends to go with the vicissitudes of the economy. So anyway, well, I hope the folks can be kept on it, long enough. That's certainly what we're trying to do with CMA and the folks that we partner with.
Of course. Thank you. And thank you again for responding to all these questions. It seems like it's pretty rapid fire today, but we still have a couple others. For IMGs, to overcome the out of practice barrier, can working as a physician assistant in the Canadian healthcare facilities for a year or so be considered as experience instead of returning back to their country of origin?
No, sorry, I don't know the answer to that. That's related to the earlier question that I said I got to look into.
Right.
And I will do that.
All right. Let's see what else. We have quite a few. We have this one question saying, thank you so much for this in-depth analysis and providing all this information. This one person is a specialist, and their question is with regards to PRA assessment and the cost related to doing PRA assessment. They say that it would be easier if they were given a short time of practice under supervision. And can that be inducted directly into a conditional license instead of pursuing PRA? Is there potential strategy around PRA or any sort of mitigation piece with regards to that as well, I guess,
Sure.
to add to her question?
Yeah, I'm going to have to look into that's sort of the piece that I'm going to have to look into. I will try and get greater clarity, and I would imagine there's a variation, but I will do my very best to get a really good answer to those questions.
Oh, thank you. And we will send those along to just kind of take a look at. And I think we have time for just about maybe one or two questions. So one of the questions that we have here is, what are your thoughts on a pan-Canadian licensure? I know that in previous discussions, in previous webinars, if those have seen the previous webinars, we know that Australia, for example, has a pan-Australian licensure model. What are your thoughts related to a pan-Canadian licensure model?
Yeah, no, the CMA supports pan-Canadian licensure, and that we've looked at Australia. Now, one difference about Australia, though, is that Medicare is a federal program, whereas it's a provincial program here. So that will make some sort of difference here. So we support that. You would need to have, and have legislation enabled in order to do that, and that we're working on that. One of my colleagues has written a paper on what some of the options are. We think it could be done without a constitutional reform, which is very unlikely to happen. I can send that. I'll send that paper to you as well, Andrew, and you can make that available.
Sure.
And then I guess then the question would be, just how would you do that? Would you have a single license issued, a single national license, or would you have would you still have a provincial territorial license that would be like your driver's license, recognized and you can drive in any province, right? Anyway, so Anyway, it's early days for that, but certainly the CMA very supportive of that.
Thank you. Thank you. And one final question. With regards to mid-career IMGs, are there any plans looking at pathways for mid-career IMGs, or is that an issue that's currently being looked at?
That I don't know. Sorry, I'll have to inquire about that. Sorry, I don't know.
That is all right. Thank you so much. We've had so many questions today, and there's been so much discussion in the Q&A. So I really appreciate being available to provide these rapid fire questions today. And so with that, are there any final thoughts or words that you would like to provide before we do sort of a final wrap up?
No, I'd just like to thank you for all the questions today and for your interest. And I'm going to do my very best to get you back some good answers on those things that I didn't know the answer to.
Thank you so much. And so with that, thank you so much, Owen, for taking time to participate in today's discussion. And many thanks to you, the audience, for joining with us and engaging with us today. And you're very much welcome to join any of our upcoming events as well, including the following in October and November, and many more. If you missed any part of today's presentation or would like to watch this session again, we will be posting this recording to our platform, to our meeting place, and to our webinars section within the next week or so. And we want to continue this dialogue, so we will be moving some more questions as well that we didn't get a chance to address to the online moderated discussion forum called the meeting place, and we'll include the responses that Owen, you're going to be taking another look at and seeing any sort of additional. So, and we invite you to very much respond to any questions on there as well, Owen. And along with that, we've curated several resources, and thank you so much for that as well, Owen, from today's webinar topic. And you can find these within our resource toolkit, and we'll be linking them when we share the on-demand version of this discussion. So if you haven't yet, please sign up to newcomernavigation.ca for all our resources and learning opportunities. Along with that, following today's session, you'll be invited to complete a survey to share your feedback with N4. These surveys help us continuously improve and seed out new webinar content and opportunities that are responsive to topics you're interested in. And we kindly ask that you follow that link and complete this brief survey. It should be in the chat as well. You should be guided to it after leaving the webinar as well. And so with that, thank you so much again. Oh, and also check out our N4 mobile app. It's available on Apple and Android devices through the QR code here on your screen, or through checking out newcomernavigation.ca/iOS or /Android. It's available in your app stores or Google Play. Thank you again, everybody. Thank you again, Owen. This has been a great discussion, great presentation, and we hope that you can join us again at a future N4 event. Stay safe and stay well, everybody.
All right, see ya.